Although autologous stem cell transplant has remained the standard of care for decades in the management of myeloma, allogeneic stem cell transplant still continues to be quite controversial, with some studies showing superiority of outcomes with allogeneic transplant over autologous, again, institution by institution. However, despite advances in control of GvHD, the reality is most patients who receive allogeneic transplant from myeloma ultimately do relapse. And there's little data about how to manage patients with myeloma post an allogeneic stem cell transplant when they relapse. Much of the issue is not only control of the disease, but the last thing you want to do is to alter the immune system in such a way as to engender GvHD. There were a number of institutions that were performing allogeneic transplants for myeloma and noticed that following the approval of Daratumumab, we all found that we were utilizing Daratumumab in this setting. I had done the study while I was at the John Theurer Cancer Center at Hackensack, and we did this in combination with Medical College of Wisconsin and City of Hope. And we pulled our data together and found that Daratumumab not only provided excellent modalities for recapturing patients post-allograft, but there was no increased signal of GvHD that you may see with some drugs such as lenalidomide. This was a retrospective study and wasn't quite well controlled for all parameters, and we used different combinations of Dara plus pomalidomide, Daratumumab as single agent. But globally, we found that Dara represented a well-tolerated backbone for patients with relapse disease post-allo without really increasing their risk of acute onset of graft-versus-host disease. So for those people who still receive allo transplants and unfortunately relapse, we do recommend a Daratumumab-based therapy.